Great. So let's talk about how to interpret palpitations, 24-hour ECGs, and exercise tests. I don't want to talk a lot about palpitations because I've done an entire separate presentation that covers palpitations in detail. But it's important to try and get as clear a description of the palpitations as possible. And it's hard for patients. Palpitations are things which often are fairly unclear symptoms. So they have vague about how frequent they are, how long they last for. It doesn't necessarily mean they're not pathological just because they're vague, but it does. It's really key questions about their onset and offset can be helpful. Palpitations that are pathological usually clear up very rapidly, so they suddenly stop. Whereas if they are um, anxiety or many other causes of palpitations, will have a rapid onset, but a less clear offset. Often the offset is more gradual, and it just sort of clears up, and they fall asleep, and they're gone in the morning. So it's important to get as clear an idea as you can about the palpitations, and don't forget to ask things about past medical history, family history, medication, and medications. Caffeine gets a lot of bad press. It's very rarely the cause of atrial fibrillation or arrhythmias generally, but if they're drinking lots of lots of Red Bull to try and stay awake while they revise, or what have you, that can rarely be a problem. And don't forget the red flags. So if there is exertional palpitations are much more concerning. Obviously, everybody gets a sinus tachycardia with exertion, so that's not particularly what I'm concerned about. But if they're exercising normally and then suddenly they notice something different about their heartbeat, that is a concern. Ventricular ectopy should be suppressed with exertion. If they've had a blackout or there's family history of serious rhythm problems, that's a big concern. A history of structural heart disease makes you many more times more likely to have a serious arrhythmia, and if your ECG is abnormal. So those are your red flags. And as I say, I've gone over palpitations much more detail in different presentations, so I'm not going to labor them here. But just as a general rule, this is what you're after. You're potentially just have a sinus rhythm, sinus tachycardia, and that's what you very commonly see if people complain of palpitations. But things like anxiety can do that, hyperthyroidism, pheochromocytoma, anemia, illness, POTS syndrome, lots and lots of possible causes there. Ventricular and atrial premature beats are very common, and some people have them 50% of the time and are unaware of them. Some people have two or three in a 24-hour period, and they're very symptomatic with those two or three. It's very variable, but look out for ventricular ectopic or atrial premature beats. Atrial fibrillation and flutter and atrial tachycardia I've sort of grouped together. Flutter and tachycardia are very similar things sometimes basically the same thing. It's semantics that there's a difference. Atrial fibrillation is quite different. So flutter and atrial tachycardia, both these are organized circuits, although an atrial tachycardia can be a bit of the heart that's going too fast. Atrial fibrillation, on the other hand, is a chaotic rhythm. So it's a different thing when it comes to treatment. We have our atrioventricular nodal reentry tachycardias and our atrioventricular reentry tachycardias. So does it go round and round in the AV node, or does it go round through an accessory pathway between the atrium and the ventricle? And obviously ventricular tachycardias. So that's what we're going to be looking for in trying to diagnose our palpitations and with our monitoring. And how should we investigate these patients? Well, 12-lead ECG, and then think about doing things like an echocardiogram or a heart monitor or an exercise test. And it's choosing the right patient for that, not trying to do it in everyone. So there are obviously different types of cardiac monitoring that we can do. The typical cardiac monitor that we apply is a 24-hour ECG with a few electrodes, which attaches to a little box you wear on your waist. You walk around with it. You obviously can't shower with it, but you can basically spend a day doing normal activity. And we really want normal activity. We don't particularly want to have somebody in hospital um, who is sitting around doing nothing. We want them to be provoking their symptoms and the arrhythmias. Um, The 24-hour monitor, that looks at the heart rhythm continuously over that 24-hour period, and we can extend that out up to a week if we want to. The team don't particularly like doing it for a whole week because it's a real hassle analyzing 7 days worth as opposed to 24 hours worth of monitor. But if you've got symptoms that are happening weekly, it can be a good way of doing things. An alternative is to put in a cardiac memo, which uh, doesn't record continuously. Instead, it it does record continuously, but not it doesn't record that. It doesn't store that information. And what you do with a cardiac memo is when you have symptoms, you activate it, and it then says, right, I will write to memory the last 2 or 3 minutes before I press you activated me, and a few minutes afterwards. And that can be very useful to get symptom rhythm correlation, which is always what we're after. So if somebody has palpitations once a month, then we could put a heart cardiac memo on for a month, and then when they get the symptoms, they can activate it. There are lots of different types of these. This is quite a snazzy little one. We went to a conference once with a load of men walking around wearing these things, which felt slightly uncomfortable. But there are other options. If these uh, are not doing the trick, if the palpitations are more infrequent, or if the person loses consciousness during the episodes and they're not going to be able to record the episode, then we can put in a implantable loop recorder. And they started off these sorts of size things, so about 2 by 6 centimeters. And now they've got really small, so they're literally injectable, and it takes 2 minutes to put one of these in. It's rather harder to fish it out again, but still not difficult. And that can monitor your heart rhythm for about 3 years. So if the heart does something funny, it will pick it up, or the patient can activate it, telling it, I've felt a palpitation, remember that. And again, actually seeing what they're experiencing is really important, because often there's nothing significant there. And so ruling out nothing is just as important as ruling it in, because that answers the patient's question, what's going on. This is a Medtronic slide, and can you see how they've artificially enlarged the appearance of the competitor device? Companies do subtle things like that. So we do 24-hour ECG in order to find out what is causing a person's palpitations. We'd also do it if somebody's very symptomatic, even if we know it's ventricular ectopy, for example. We might want to know how frequent, what the burden over a 24-hour period is. And we can do 24-hour ECGs repeatedly in order to see that we've rate controlled the atrial fibrillation, for example. It can also be used to assess autonomic function, and that's not something that we use it for clinically. I mean, we could do it and say this person's not very healthy, their autonomic function's pretty poor, and it does give us a feel of if they've got a very flat um, trace, that they're more likely to need a pacemaker, but it's not something we act on. But if you're doing research and you want to research autonomic function, 24-hour ECG is a great way of doing it. So I've spoken enough for now. Let me have a rest, and you can tell me what normal can look like on a 24-hour ECG. So what findings would you class as being normal? Let me put a few suggestions. Any of these you consider to be normal, abnormal? The short answer is it's very tricky to know. And particularly in a young person, we don't do 24-hour ECGs in young people unless we're looking for pathology. And you then find pathology, don't know what to do with it. It can really open up cans of worms that we'd much rather leave unopened. Um, so investigate where appropriate, but don't do tests if you can avoid it, because actually knowing what normal is in a young person is very hard. And if there ever was a research study looking at doing 1,000 normal people's 24-hour ECGs, I'm not sure I'd volunteer for it because I don't know I want to find anything. On the other hand, what is abnormal? Well, first thing I would say is always consider the patient. So what is normal for a young person? Say you have a 20-year-old who's fit and athletic, and they're having Venki back on their 24-hour ECG during daytime hours, but it turns out they work night shifts and they're asleep during the day. Well, that's completely normal. If they're Venki backing during the day when they're at rest, that would be a bit odd. If an 80-year-old is having Venki back on their ECG, their 24-hour ECG, particularly during the day, that's very abnormal. So consider the patient. And we always want to know their symptoms at the time of the rhythm, because we want to know, have we identified why they've come to us in the first place? And we want to know, is treating that going to make the patient better? So with that in mind, what would you say is definitely abnormal on a 24-hour ECG? What are you specifically looking for? Well, I'm glad that I'm not inundated with answers, because this is not stuff that I think you're generally taught, which is partly why I put this presentation together. Things which are definitely abnormal would be non-sustained VT. And non-sustained VT is 3 or more beats of ventricular beats together. So you don't have to have very much for it to be non-sustained VT. What's sustained VT? How long does it have to last for it to be sustained? Does anybody know the answer to that? So the answer is over 30 seconds. So 3 beats or more is non-sustained VT. 29 seconds worth of maybe 60 beats is still non-sustained VT. It has to be over 30 seconds to be sustained. So it's slightly arbitrary. You can see how much more concerned you might be about 29 seconds of it than you would be about 3 beats of it. But that's definitely not a normal finding. So that would, if I saw that on my 24-hour ECG, I'd want to do an echocardiogram and see that my structure and function were normal. If they were normal, I wouldn't really know what to do with it, but it certainly would be something that I wouldn't like. Evidence of heart block is abnormal. So look for evidence of heart block. If you see it even during the night, that's something that needs further consideration. Venki-Bach, we said, is okay, particularly in young people, but 2 to 1 or higher is even brief complete heart block needs a pacemaker. Looking for pauses over 3 seconds during the day, over 5 seconds at night. And look for evidence of atrial fibrillation. Atrial fibrillation is always an important thing to find. When we see short runs of narrow complex tachycardia, that can be very difficult to know for sure if it's AF or if it's a short run of AVNRT. And it's hard to know what to make of it. So it's these sort of things can be difficult to say are definitely abnormal. This would be my list of things that are arguably abnormal. So let's have a look at some 24-hour ECGs now and interpret them. So this is an example of a patient complaining of palpitations. And this is the front sheet of their 24-hour ECG. And try and avoid immediately looking at the comments because it is your responsibility to interpret this. The technician have done their best, but if they've got it wrong, it's still down to you to spot that their interpretation is wrong. Have a look at the aberrant total. So this is telling you the number of ventricular ectopic beats, ventricular premature beats. That's what the aberrant total is. And this is the total number, and then the number of couplets, triplets, salvos, basically runs of VT. And this could be atrial or ventricular ectopic beats. Also, it tells you things like how many pauses there are. I don't particularly look at maximum minimum heart rates. I'll come on to that in a second. And then once I've looked at really this figure, and actually the reports have changed slightly, but that figure is still on there in a slightly different place. The next thing that I do is look at the rate profile over 24 hours, which is this graph here. Can you see the time along the x-axis and the heart rate along the y-axis? And now you can see the heart rate variability. And now you can look at the heart rate maximum, but more than that, you can see how much of the time it's at the maximum. That's why I don't bother looking at it in the front sheet. I want to get a better feel for heart rate profile, and maximum and minimum are the most unrepresentative values of a data set. So you want to see the profile. And here, can you see it appropriately dips at night? There's a surge of an increase when the patient wakes up in the morning, and it varies. This is good autonomic function. So this is a very reassuringly normal appearance of a 24-hour ECG heart rate. And then look in at the detail of the report. And can you see we have a patient event and we have two ventricular ectopic beats together. That's a couplet. That's happening a few times. There are also some other premature normal beats or ventricular ectopic beats. In fact, this is an atrial ectopic. These aren't associated with symptoms. And we then look at the diary and we can see that they're getting very brief palpitations. Walking, I wouldn't count as really exercise, unless it's a vigorous form of exercise for the individual. So here we have symptom rhythm correlation, ventricular ectopic beats. It's a bit queasy that there's a couplet rather than a single beat, which wouldn't give me any pause at all. I might be thinking about an echocardiogram. I'd certainly be asking about family history, but there's probably not a lot to do here. And usually reassurance is all that's required. This patient's only having 18 or so in a 24-hour period, so it doesn't look like it's a very frequent thing. But we can ablate these if patients have desperate symptoms. It's just a real sledgehammer to crack a nut. So reassurance would be very much the main thing. Alternatively, a beta blocker will suppress these quite nicely, but could end up making the patient go a bit slowly. So let's move on. This is example number 2. And I've honed in on the bit, as I say, which I think is most useful, which is the 24-hour rate profile. What do you think of this? Anybody want to comment on this rate profile over 24 hours? So the big things that I want you to spot are that the rate goes up and down in a stepwise fashion. Here it's going pretty slowly and then suddenly it shoots up before rapidly falling back down again about half an hour later. And it does that a number of times during the 24-hour period. immediately looks like there are two different things going on, and that the rhythm here is going to be different to the rhythm here. And so we immediately should then look at ECGs from those two different time points to see what's going on. And when we do that, we can see that we've got a sinus bradycardia here, and we've got a atrial fibrillation during the fast heart rhythms. So what are you going to do about that? Yeah, so the difficulty here is we're not going to be able to slow these faster rates down without making them go too slowly, but the rate isn't that fast. So if they're asymptomatic, we could leave them alone. If we're going to need to slow them down or add in a beta blocker or other rate control medication, then a pacemaker is likely to be required. Incidentally, can you see there's an atrial ectopic landing on top of the T wave, which is non-conducted, which is why there's this slightly odd appearance. And very good anticoagulate. Don't forget to anticoagulate the patient. Um, what about this example? What will you do with this, other than wish you hadn't requested a 24-hour ECG in the first place? Yeah, so imagine that you were working in a GP surgery and you had a 25-year-old who complained of palpitations, and you decided to do a heart monitor and you got this back again. So a bit more history is always helpful, but this is VT, and therefore the patient is going to need to be admitted and further assessed. Can you see that this is about 15 seconds worth of VT? So this is still non-sustained VT, but it's very concerning that we should be seeing such long runs and frequent runs, two in the same breath almost. So this certainly needs inpatient assessment. What about this one? So similar to the previous one I showed you, we've got two different heart rates, but more than that, we're going very fast here and we're going relatively slowly here. And it's unlikely that we'd be able to rate control this without going too slowly here. So this is the kind of patient that almost certainly needs a pacemaker, and we call this tachybrady syndrome, where they're going too fast and too slow. So this patient does need rate controlling, whether or not they're asymptomatic. I don't allow rates of over around 110 in atrial fibrillation, even when asymptomatic. At rest, obviously, exercise it increases. How about this one? So imagine you're on the wards, imagine you're on ward 28, which is where this came from, and a patient has this appear on their monitor and you're working a night shift. It's 2 o'clock in the morning and you've got lots going on everywhere else, but you've been asked to come and see this ECG. Or in fact, even better, it was done at 8:26 in the morning and you've been called at 8:30 and you need to go and hand over. And the last thing you want to do is be stuck on the ward dealing with this with this patient because it's going to delay you going home at the end of your shift. Yeah, so we'd assess the patient, see if they've got a pulse or not. So the very important to know, was the patient symptomatic for this? Do you think the patient was symptomatic? So if this is polymorphic VT, which is what it looks like, or possibly VF, but it's, you know, it's very fast. I suppose actually it does look more like VF in terms of just how fast it is. So this rate, it's hard to tell on a 24-hour ECG, cardiac monitor, because the scale isn't what you're used to. But the rate here is going to be probably around 300, so it's pretty fast. Um, but these three leads are recorded simultaneously. And if you look at the third lead down, can you see how you can track QRS complexes all the way through this? And in fact, what you have is atrial fibrillation, and the patient has caused an artifact which looks like an arrhythmia. So distinguishing artifact from arrhythmia is important when you do a 24-hour ECG, because obviously muscles have got run by electricity just as the heart is. This could be the patient brushing their teeth, for example. So look out for artifact when you're trying to interpret a 24-hour ECG, and use the fact that three leads are recorded simultaneously, and one of the leads hopefully is a little less affected by the artifact than the others. I mentioned earlier that the 24-hour ECGs can be very good for doing research. This is an example of a fascinating research paper that I found involving 24-hour ECGs. Let's move on and talk about exercise tests. I don't want to spend too long on this because you don't do exercise tests as much as we used to, which I do think is a shame. There used to be a lovely test. It used to be something very satisfying about flogging somebody and making them work really hard. Um, why do we do it? We're looking for evidence of ischemia. That has really gone out of favor now. We rather do cardiac CTs, which I don't like much, but that's what NICE recommends. We still do it now to assess for arrhythmias, and arrhythmias with exercise are a concerning feature. So it's not all that common, but they will be the ones you tend to get called to supervise, because they do need supervision in case of VT and need for resuscitation. And we also do them to assess symptoms, and cardiopulmonary exercise tests are still done quite a lot, and I think are underused. I did one today on somebody who complained of severe breathlessness, and it basically showed that they were unfit and didn't try hard enough. And that's really useful information that they found very helpful, and that it's can be very helpful doing cardiopulmonary exercise tests. But this, I'm more just going to talk about bog standard exercise tests, save cardiopulmonary exercise tests to another day, because that's quite a complex topic. Why don't we use it nowadays for ischemia testing compared to CTs? Well, we do tend to like doing expensive tests. We tend to favor research into expensive tests, and then they change the guidelines with them. But also, if you have a young 30-year-old who's got chest pain, an exercise test is a really great way of assessing them. Whereas if you have a 60-year-old who's obese and doesn't do any exercise, it becomes not a particularly helpful test. So let's have a look at some interpretation, and I'll give you a bit more theory. Imagine we have a 55-year-old woman who's overweight, is type 2 diabetes, and has got breathlessness and exertional chest tightness. Now, Women's exercise tests are harder to interpret because the ECG appearances that are within normal limits can be a bit more confusing. Postmenopausal, it's not so much of an issue. So if this lady's postmenopausal, an exercise test becomes reasonable. If she's premenopausal, it wouldn't be a great first option. So what do you think of this? This is your summary slide. And you can see the maximum heart rates, 165. We want people to get up to within 85% of their maximum heart rate. Otherwise, we say they've not really done enough exercise. So calculate that, and that's 140 beats per minute. So we then get the patient to exercise, and they get up to 156 beats per minute. So that's above the 85%. So that's a sufficient exercise test. Can you see the blood pressure goes up? It really goes up a lot. So that's an exaggerated increase in blood pressure, but it also comes down quite rapidly at the end, and the heart rate comes down quite quickly at the end. So that's a good sign that the heart rate recovers quickly. Now, this is an ECG at rest, and this is a fairly normal resting ECG. I hope you agree with me. And then at stage 2, when she's at maximal exercise, this is what her ECG looks like. And do you think there's ST depression? Do you think there's some upsloping ST depression? Well, there is, I think, fairly widespread upsloping ST depression. And is that abnormal? Is that a concerning feature or not? Well, the technician didn't think so, but the cardiologist did. Who was right? Well, it's not so much a case of who was right. Was the suspicion here high enough to need a further test? Because even if only 1 in 20 further investigations show something, if that shows something that needs treatment, then it's worth doing another test. So you have to be very sure that you've ruled something out. And this is where exercise tests become out of favor, because here, this is a negative test, and this patient didn't have ischemic heart disease. They were just unfit. But they ended up with another test in order to show that. So it was a waste of money doing the exercise test in the first place, you could argue. So this is why we don't do them so much these days. So this is an example of a negative test result in somebody who's relatively unfit. The sensitivity specificity of exercise tests about 78% sensitive, 70% specific, but it's raw numbers like that don't really give you the importance of it, because if if you've got left mainstem disease, the sensitivity is much greater than 78%. So for serious coronary artery disease, exercise test is a really good rule out. The Courage trial looked at getting patients to exercise, and if they got out of stage 1 of the full Bruce protocol before there was any ST change, they were managed conservatively, and they did very well. So there's good data that it actually an exercise test is a way of assessing somebody's risk going forward. But when you've got sensitivities and specificities, it always depends enormously on how likely the cohort of patients is to have coronary artery disease. I mean, if you only did the test on patients with coronary artery disease, then of course the specificity would be 100%, because everyone with a positive test result, whether it was looking at if they had brown hair or not, everyone with brown hair in that group will have coronary artery disease because they've all got it in the first place. So sensitivities and specificities very much depend upon the cohort being tested, but it's not a great test. It's not a highly accurate test. But as I've said, if you've got a young person who can do a good amount of exercise, it can still give useful information. If I develop chest pains, I'd rather have an exercise test than a CT because I know I'll be able to exercise enough to show if I've got a problem. We do something called the full Bruce protocol. There's 7 stages. We never get to 7 stages. We only ever get to the end of stage 4. And each one lasts 3 minutes. They start off by walking at 1.7 miles per hour up a 10% incline. So that's pretty slow walking pace, but that's quite a steep incline. And that's using about 4.8 metabolic equivalents. I'll tell you what a met is in a second. And each stage it gets steeper and faster. And by the time it gets to stage 4, unless you're pretty fit, then you will start to struggle. If the patient can't do a full Bruce protocol, we can do the modified Bruce, which is more gentle. That's basically half as vigorous as the full Bruce. But you start to wonder, are you going to get any useful information out of it? So we don't tend to do those nowadays. So what is a MET? Well, a MET is basically how much oxygen you're consuming at rest. So 4.8 is about 5 times as much as you're doing at rest, and that's roughly what we would consider necessary to carry out the activities of daily living. So really everybody, hopefully, who isn't very frail would be able to get through stage 1. But stage 2 is fairly modest exercise. Stage 3 is modest exercise. It's not particularly vigorous. I'm actually doing a research study looking for some recruits at the moment to do exercise tests. So, but actually won't be starting to do those until August, when I think most of you will have moved on. What should we do to prepare the patient? Well, probably beta blockers should be discontinued, but it depends. If they've got AF, we certainly shouldn't do that. And even for DVLA exercise tests, the DVLA quite like exercise tests to assess if patients can drive heavy goods vehicles, a Group 2 license. They allow you to keep Yanchang on these days. So that's probably not accurate, but if you really wanted to find out if they've got ischemia, then beta blockers can stop you from achieving your target heart rate and stop you from developing the ischemia. Digoxin, on the other hand, that will confuse your interpretation of the test. So either stop it a long time beforehand or don't do it. And similarly, anti-anginals, we probably would just leave on these days. I talked about the maximum predicted heart rate. So that's 220 minus patient's age for a woman, 210 minus the patient's age for a man. And we're aiming to get to 85% of the maximum predicted. And if you can get to the maximum predicted heart rate, that's a good prognostic sign. So let's have another look at another example. Imagine this time we have a 50-year-old man and he's got 1 week history of exertional chest tightness. So it's a good patient if he's reasonably fit to find out if there's a problem or not. So this is the exercise test. He manages just 3 minutes, 23 seconds of the full Bruce protocol. So he doesn't do very much exercise. He only gets to 114 beats per minute. So he hasn't got to 85% predicted. So it's not a sufficient exercise test for diagnostic purposes unless it shows ischemia. Blood pressure goes up from a relatively high level, comes down to the relatively high level. That's his ECG at rest, which I hope you'll agree is a fairly normal resting ECG. And at the start of exercise, this is 10 seconds into exercise, hasn't had chance to change very much. Now at 2 minutes 52 seconds, so this is still in stage 1 of the full Bruce exercise test. So this is just activities of daily living, minimal exercise. And can you see abnormalities on this ECG? So here, can you see there's horizontal ST depression of about 2 millimeters, and there's horizontal ST depression here. Varies a bit beat to beat. So look at the average. You could say this is a bit downsloping. But look at the average, I think you'd say it's horizontal. The location of the ST depression doesn't tell you where in the heart the narrowing is, but this is a very definitely positive exercise test, and it gets even deeper within a few more seconds, and the technicians very appropriately identify this and stop the test. So this is what you're looking for if you're ever supervising a test. Don't worry, the techs are very good at spotting this sort of thing. Really, you're really there to deal with any emergencies like VT. We also look at how rapidly it recovers in recovery. So a minute into recovery, it's still there. By about 7 minutes into recovery, it's settled down. So this tells you this is a high-risk individual who needs an urgent coronary angiogram to find out what's going on with his anatomy. I normally say that patients should be managed conservatively. Well, that's certainly true, but based on exercise tests, if you get ischemia before 3 minutes, that tells you they're a high risk person who ought to be have coronary angiogram and consider if surgery is required. Why might we not do an exercise test? Well, it's one of those fairly obvious things: very high blood pressure, severe aortic stenosis, unless we're assessing the aortic stenosis, uncontrolled angina, recent infarct, DVT. I don't think you really need to memorize this list. You're not going to say, I've got someone with an aortic dissection, I'm going to do an exercise test on them. Oh, I've highlighted these because actually we do exercise tests in these two conditions sometimes to assess symptoms. We talked about the limitations and the fact that we do get false positives. Frail patients obviously can't do it, and conduction tissue disease can cause trouble. Let's have one more example. This is a 65-year-old man. He's had a previous anterior MI, and he's come back in with exertional chest pain. His troponin's negative. So the team decide to exercise him. And can you see his heart rate starts at 88? So it's a bit on the high side, but he's probably a little bit stressed. Blood pressure's good. Blood pressure goes up well. We can see that his heart rate increases appropriately. We get up to 177, which is actually quite considerably over the 85% maximum, 142. In fact, it's above his actual maximum heart rate. So we probably pushed him a little bit too hard. So have a look at his resting ECG. What do you think of that? Can you see that there is poor R wave progression? In fact, there are anterior Q waves. So this is evidence of a previous anterior myocardial infarction. A bit of T wave flattening, but otherwise okay. So definite history of ischemia fits with the ECG. And fix your eyes on what that looks like, and then have a look at what it looks like when he's been exercising for about 5, maybe 6 minutes. Any evidence of ST depression? Well, there's a little bit. This is upsloping here. Upsloping ST depression we don't worry about so much, although it's harder to interpret. Certainly it's okay in women. What means for somebody like this is harder to say. Do you think these T waves are normal? Do you think they might be looking a little bit more upright than these? Yeah, could just be the heart rate. So we're reasonably satisfied so far. The patient is asymptomatic. We carry on exercising them. What do you think about this? Well, can you see now they are developing ST elevation, which is quite marked, and we don't quite know what to do with that when it's in leads with Q waves in it. If that was in a lead without a Q wave, then that would be an immediate stop criteria, and this, to be honest, is a definite stop criteria with the extent of elevation we've got here. And then the patient goes into VT and arrests. So that's why you need to watch the ECG quite carefully, looking for things like ST elevation. And of course, they had a doctor in tow, a junior doctor like one of yourselves, who shocked the patient out of the VT, and all was well. Patient had a coronary angiogram and had a stent put in. Whether or not they definitely needed the stent or not is a bit arguable, because they did rather a lot of exercise before developing a problem. But we provoked something, and then we did another test, and then we did. Um, there is about a 1 in 10,000 risk of an acute MI, much smaller risk of death. It, this is for patients with a history of ischemic heart disease. If you did an exercise test for me in my research study, I'd hope that your risk was much smaller than that. And there is a risk of VTVF, so that's why they do need some supervision. We're looking for, so this is an example of normal. So STs can look to go down very slightly, but not a lot. And then they can be a bit upsloping with exercise, and that's normal. And that's the text way of describing that, if you like text rather than pictures. When should we stop? If we've got ST depression more than 3 millimeters, once you get to 2 millimeters with symptoms, you've got enough information, you should stop. But without symptoms, we might let it go a little bit further. But if there's any ST elevation in a non-QA bleed, that's an immediate stop. If it's a QA bleed, it's a bit harder to know. If you're having lots of ventricular extrasystoles that are increasing with exercise, that's a concern. Unless you're doing it specifically to investigate ventricular arrhythmias, that would be a stop, and consider why that's happening. And then VT, obviously we stop. AF is a bit harder. Usually the rate shoots up fast in the AF, so that would be a reason to stop. A new bundle branch block can affect your interpretation, or could be a sign of ischemia. So obviously reasons to stop. Clinical reasons: if the patient requests you stop, if they get chest pain, if they you think is worthy of stopping. If they get a mild twinge, then you might just say, well, let's give them another minute and then reassess. But if it's clear cardiac chest pain, then they definitely need to stop. If their blood pressure drops, that's a concerning feature. That's a stop. And if their blood pressure goes up very high, I found this paper when I was searching for the threshold, and it said that they only stopped if blood pressure exceeded the 300 millimeters mercury that the SFIG would go up to. No, that's a paper from 2005. There aren't really official guidelines, international guidelines, but this is our departmental stop if your blood pressure is over 230 over 115. And then after the exercise test, record up to 15 minutes until you're satisfied that everything has settled down, and look for ECG changes during, or arrhythmias during, the recovery phase, which are just as important as those occurring during exercise. Great. Well, that's everything I wanted to talk about exercise tests and 24-hour ECGs. Any questions at all?